Welcome back to DHA GP exam preparation. In this video, we are covering 20 cardiology questions straight from the DHA blueprint, covering ischemic heart disease, heart failure, arrhythmias, and hypertension. For each question, I will give you a few seconds to think before I reveal the answer, and I will explain not just why the correct answer is right, but why each of the other options is wrong. That second part is where the real learning happens. So let's get started. Question number 1. A 58-year-old man presents with crushing central chest pain radiating to the left arm for the past 45 minutes. ECG shows ST elevation in leads 2, 3 and AVF. The nearest PCI capable center is 3 hours away. What is the most appropriate next step? Option A. Administer thrombolytic therapy immediately. Option B. Transfer to PCI center regardless of delay. Option C. Start high-dose statin and observe. Option D. Perform stress test to confirm ischemia. The correct answer is A. Administer thrombolytic therapy immediately. Primary PCI must occur within 120 minutes of first medical contact. A 3-hour transfer exceeds this window, so thrombolysis within 30 minutes. Now, why isn't B correct? Because exceeds the 120 minutes PCI window prolongs ischemia unnecessarily. And why isn't C correct? Statins don't treat an evolving STEMI. This delay reperfusion. Now, why isn't D correct? Diagnosis is already confirmed by ECG. Stress testing in acute STEMI is contradicted. Now, let's move on. Question number 2. A patient with an inferior wall STEMI develops hypotension after receiving sublingual nitroglycerin. What is the most likely explanation? Option A. Anaphylaxis to nitroglycerin. Option B. Right ventricular infarction with preload dependence. Option C. Cardiogenic shock unrelated to nitrates. Option D. Vasovagal reaction. The correct answer is option B. Right ventricular infarction with preload dependence. Inferior MI often involves with right ventricle, which becomes preload dependent. Nitrate reduced preload, causing a sharp drop in cardiac output and blood pressure. Now, why isn't A correct? Nitroglycerin allergy is exceedingly rare and doesn't fit the classic pattern. Now, why isn't C correct? The clear temporal link to nitrate administration points to a drug effect, not a coincidental unrelated shock state. Now, why isn't D correct? Vasovagal reactions are typically linked to pain or anxiety with bradycardia, not specifically triggered by nitrates here. Let's move on to the next question. Question number 3. A 65-year-old woman with type 2 diabetes and non-heart failure with reduced ejection fraction is already on an ACE inhibitor, beta blocker and spironolactone. She continues to have exertional dyspnea. Which class of medication should be added next for mortality benefit? Option A. SGLT2 inhibitor. Option B. Non-dihydropyridine calcium channel blocker. Option C. NSAID for symptomatic relief. Option D. Short-acting nitrate as needed. The correct answer is option A. SGLT2 inhibitor. SGLT2 inhibitors are part of the 4-pillar heart failure reduced ejection fraction therapy. ACE inhibitors, beta blockers, MRA, SGLT2I, and reduced mortality or hospitalization regardless of diabetes status. Now, why isn't B correct? Negative ionotropic effect avoided in heart failure reduced ejection fraction as it can worsen heart failure and mortality. Why isn't C correct? Causes fluid retention and blunts ACE inhibitor diuretic effect, never used for symptom relief in heart failure. Now, why isn't D correct? May help angina symptoms but has no proven mortality benefit in heart failure reduced ejection fraction. Let's move on. Question number 4. Which of the following is a mortality reducing therapy in heart failure reduced ejection fraction as opposed to being purely symptomatic? Option A. Furosemide. Option B. Beta blocker. Option C. Digoxin. Option D. Hydralazine alone. The correct answer is B. Beta blocker. Beta blockers, ACE inhibitors, ARB, ARNI, MRAs, and SGLT2 inhibitors have all shown mortality benefit in heart failure reduced ejection fraction. Now, why isn't A correct? Relieves congestion or symptoms but never shown to reduce mortality in heart failure reduced ejection fraction. Now, why isn't C correct? Reduces hospitalizations and improves symptoms but has a neutral effect on mortality. Why isn't D correct? Only has mortality benefit when combined with a nitrate, not as monotherapy. Next question. Question number 5. A 72-year-old man with atrial fibrillation has a CHA2DS2 VAS score of 3. What is the most appropriate management regarding stroke prevention? Option A. No anticoagulation needed. Option B. Aspirin alone. Option C. Oral anticoagulation. Option D. Clopidogrel alone. The correct answer is option C. Oral anticoagulation. A score of more than or equal to 2 in men crosses the threshold where anticoagulation clearly reduces stroke risk. Now, why isn't A correct? A score of 3 is well above threshold, withholding anticoagulation leaves significant preventable risk. Why isn't B correct? Aspirin monotherapy is inferior to anticoagulant for stroke prevention in atrial fibrillation and is no longer recommended. Why isn't D correct? Antiplatelet monotherapy doesn't address the cardioembolic mechanism as effectively as anticoagulation. Let's move on to the next question. Question number 6. A 45-year-old man presents to the ER with BP of 220/130 mmHg, blurred vision, headache, and papilledema on fundoscopic exam. What is the most appropriate initial management? Option A. Oral amlodipine discharged with follow-up in 1 week. Option B. IV antihypertensive with gradual reduction of MAP by 25% in the first hour. Option C. Rapid normalization of BP to 120/80 within 30 minutes. Option D. No treatment needed since patient is asymptomatic of chest pain. The correct answer is option B. IV antihypertensive with gradual reduction of MAP by 25% in the first hour. Papilledema or encephalopathy equals hypertensive emergency, end organ damage. IV agents with controlled MAP reduction similar to 25% in 1 hour avoid cerebral hypoperfusion. Now, why isn't A correct? Outpatient management of hypertensive emergency risk stroke, vision loss, or death. Why isn't C correct? Overly rapid correction can cause cerebral hypoperfusion and ischemic stroke. Why isn't D correct? End organ damage doesn't require chest pain to qualify as an emergency. Urgent treatment is mandatory. Next question. Question number 7. A pregnant woman at 28 weeks gestation is found to have a BP of 150/95 mmHg on 2 occasions. Which antihypertensive is contradicted in her management? Option A. Labetalol. Option B. Nifedipine. Option C. Lisinopril. Option D. Methyl-dopa. The correct answer is option C. Lisinopril. ACE inhibitors are contradicted in pregnancy. Teratogenic, cause fetal renal damage, oligohydramnios, and skull ossification defects. Now, why isn't A correct? Labetalol is preferred, safe first-line agent in pregnancy. Why isn't B correct? Nifedipine is safe and commonly used in pregnancy-related hypertension. Why isn't D correct? Methyl-dopa is a classic first-line agent with a long safety record in pregnancy. Next question. Question number 8. Which first-line antihypertensive class is generally preferred as initial monotherapy in Black patients without compelling indications given comparatively reduced efficacy of another class in this population? Option A. ACE inhibitors. Option B. Beta blockers. Option C. Calcium channel blockers or thiazide diuretics. Option D. Alpha blockers. The correct answer is option C. Calcium channel blockers or thiazide diuretics. ACE inhibitor monotherapy shows reduced efficacy in this population due to lower average renin activity. CCBs or thiazides are preferred first line. Now, why isn't A correct? Reduced BP lowering efficacy as monotherapy in this population, still used if compelling indication like CKD or diabetes. Why isn't B correct? Not first line for uncomplicated hypertension in any population. It is reserved for compelling indications post MI or heart failure. Now, why isn't D correct? Not first line at all. Reserved for third or fourth line due to inferior outcomes shown in trials. Let's move on to the next question. Question number 9. A 60-year-old man presents with chest pain and his troponin is elevated but his ECG shows no ST elevation. What is the most likely diagnosis? Option A, STEMI. Option B, NSTEMI. Option C, unstable angina. Option D, stable angina. The correct answer is option B, NSTEMI. NSTEMI is defined by elevated cardiobiomarkers, troponin, without ST elevations on ECG. Now, why isn't A correct? STEMI requires ST segment elevation on ECG, which is explicitly absent here. Why isn't C correct? Unstable angina has a similar picture, but by definition, normal troponin. Elevated troponin confirms NSTEMI instead. Now, why isn't D correct? Stable angina doesn't cause troponin elevation and is not an acute presentation. Question number 10. In the initial management of a patient with suspected ACS, which combination represents appropriate first-line therapy? Option A, aspirin, oxygen only if hypoxic, nitrates and beta blocker. Option B, high flow oxygen for all patients regardless of saturation. Option C, NSAIDs for pain control. Option D, immediate high dose corticosteroids. The correct answer is option A, aspirin, oxygen only if hypoxic, nitrate with caution, beta blockers. Routine high flow oxygen is no longer recommended unless hypoxic, SpO2 less than 90%. Aspirin causes nitrates and beta blockers form the foundation of ACS management. Now, why isn't B correct? Hyperoxia in normoxic ACS patient may cause coronary vasoconstriction and worse outcomes. Now, why isn't C correct? NSAIDs, except aspirin, increase cardiovascular risk and interfere with aspirin antiplatelet effect. Why isn't D correct? Corticosteroids have no role in ACS management and are not part of any standard protocol. Let's move on to the next question. Question number 11. A 55-year-old man with atrial fibrillation and rapid ventricular response is hemodynamically unstable, BP 80/50, altered mental status. What is the most appropriate immediate management? Option A, IV metoprolol for rate control. Option B, oral anticoagulation and outpatient cardiology referral. Option C, synchronized electrical cardioversion. Option D, digoxin loading dose. The correct answer is option C, synchronized electrical cardioversion. Hemodynamically unstable atrial fibrillation with RVR requires immediate synchronized cardioversion regardless of anticoagulation status. The instability is life-threatening. Now, why isn't A correct? Medication-based rate control is too slow and can further drop BP in an already unstable hypertensive patient. Why isn't B correct? This patient needs immediate inpatient emergency intervention, not outpatient follow-up. Why isn't D correct? Digoxin has a slow onset of action, not appropriate for acute hemodynamic instability. Let's move on to our next question. Question number 12. Which of the following best differentiate hypertensive urgency from hypertensive emergency? Option A, the absolute blood pressure reading alone. Option B, presence or absence of end organ damage. Option C, patient's age. Option D, whether the patient has diabetes. The correct answer is option B, presence or absence of end organ damage. The key distinguishing feature is end organ damage, encephalopathy, papilledema, acute kidney injury, pulmonary edema, and dissection. Emergency requires IV therapy. Urgency can use oral agents. Now, why isn't A correct? Two patients can share identical BP readings, but not the one with end organ damage is an emergency. Why isn't A correct? Two patients can share identical BP readings, but only the one with end organ damage is an emergency. Now, why isn't C correct? Age is not part of the urgency or emergency distinction. Now, why isn't D correct? Diabetes is a general risk factor, not the defining criterion for this classification. Let's move on to the next question. Question number 13. A 70-year-old woman with heart failure reduced ejection fraction is prescribed spironolactone in addition to her ACE inhibitor and beta blocker. What laboratory parameter requires close monitoring after starting the medication? Option A, serum potassium. Option B, serum sodium only. Option C, fasting glucose. Option D, liver function tests. The correct answer is option A, serum potassium. Spironolactone potassium sparing combined with an ACE inhibitor carries significant hyperkalemia risk. Potassium and renal function needs close monitoring. Now, why isn't B correct? Sodium isn't the critical concern with the specific drug combination. Why isn't C correct? Spironolactone has no significant direct effect on glucose metabolism. Why isn't D correct? Spironolactone isn't associated with significant hepatotoxicity. LFTs aren't the priority here. Question number 14. A patient on warfarin for atrial fibrillation needs to switch to a direct oral anticoagulant due to a difficulty with INR monitoring. Which of the following is a contraindication to direct oral anticoagulant use? Options. Option A, non-valvular atrial fibrillation. Option B, mechanical heart valve. Option C, mild renal impairment. Option D, age over 65. The correct answer is option B, mechanical heart valve. Direct oral anticoagulants are contraindicated with mechanical heart valves and moderate severe mitral stenosis. Trial data showed worse outcomes with DOACs. Warfarin remained standard. Now, why isn't A correct? This is actually the classic, well-supported indication for DOAC use. Why isn't C correct? Mild impairment may need dose adjustments for some DOACs, but doesn't contraindicate use outright. Why isn't D correct? Age alone is not a contraindication. DOACs are commonly and safely used in older adults. Let's move on to the next question. Question number 15. A 50-year-old man reports intermittent chest tightness on exertion that resolves with rest, lasting about 5 minutes each episode, with no change in frequency or severity over the past 6 months. What is the most likely diagnosis? Option A, unstable angina. Option B, stable angina. Option C, NSTEMI. Option D, Prinzmetal angina. The correct answer is option B, stable angina. Stable angina, predictable, exertional pain resolving with rest with a consistent pattern over time. Why isn't A correct? Implies a change in pattern, new onset, increasing frequency or severity, or rest pain, none of which is described here. Why isn't C correct? Requires evidence of myocardial injury, elevated troponin, not mentioned, and inconsistent with a stable resolving pattern. Now, why isn't D correct? Caused by coronary vasospasm, classically at rest, often at night, not exertional or predictable like this case. Let's move on to the next question. Question number 16. In a patient presenting with new onset heart failure, which class of medication should generally be avoided due to worsening fluid retention and reduced efficacy of diuretics? Option A, ACE inhibitors. Option B, NSAIDs. Option C, beta blockers. Option D, SGLT2 inhibitors. The correct answer is option B, NSAIDs. NSAIDs cause sodium or water retention and blunt the effect of diuretics and ACE inhibitors, worsening heart failure control. Now, why isn't A correct? A cornerstone, mortality benefiting heart failure therapy, not something to avoid. Now, why isn't C correct? Also foundational, mortality reducing heart failure therapy once the patient is stabilized or euvolemic. Why isn't D correct? Part of standard 4-pillar heart failure reduced ejection fraction therapy with proven benefit, the opposite of something to avoid. Let's move on to the next question. Question number 17. A 68-year-old man with long-standing hypertension presents with sudden tearing chest pain radiating to the back and a blood pressure discrepancy between his two arms. What is the most likely diagnosis? Option A, acute pericarditis. Option B, aortic dissection. Option C, pulmonary embolism. Option D, musculoskeletal chest pain. The correct answer is option B, aortic dissection. Tearing pain radiating to the back plus an arm BP discrepancy is classic for aortic dissection, a surgical emergency requiring urgent CT angiography and BP control. Now, why isn't A correct? Pericarditis pain is typically sharp or pleuritic, worse lying flat and better leaning forward, no arm BP discrepancy. Why isn't C correct? Pulmonary embolism classically presents with pleuritic pain, dyspnea and hypoxia, not tearing pain with arm BP discrepancy. Why isn't D correct? Wouldn't explain the systemic finding of BP discrepancy, a specific red flag for dissection. Let's move on to the next question. Question number 18. Which of the following medications is first line for acute rate control in a hemodynamically stable patient with atrial fibrillation and rapid ventricular response, particularly if the patient also has reduced ejection fraction? Option A, verapamil. Option B, diltiazem. Option C, digoxin. Option D, beta blocker. The correct answer is option D, beta blocker. Beta blockers are preferred for rate control in reduced ejection fraction. Non-DHP calcium channel blockers are avoided due to negative inotropic effects. Now, why isn't A correct? Negative inotrop, avoided in reduced ejection fraction as it can precipitate or worsen heart failure. Why isn't B correct? Same issue as verapamil. Negative inotropic effect is harmful in heart failure, reduced ejection fraction. Why isn't C correct? Can be used as add-on, but it is not the first line monotherapy due to slower onset and narrow therapeutic index. Question number 19. A patient is found to have an LDL cholesterol of 165 mg/dl along with established coronary artery disease. What is the most appropriate first-line pharmacologic therapy? Option A, fibrate therapy. Option B, high-intensity statin therapy. Option C, niacin. Option D, omega-3 fatty acid supplementation alone. The correct answer is option B, high-intensity statin therapy. High-intensity statin therapy is a first-line in established atherosclerotic cardiovascular disease to achieve substantial LDL reduction and reduce cardiovascular events. Now, why isn't A correct? Primarily targets triglycerides, weaker evidence for reducing cardiovascular events versus statins. Why isn't C correct? Largely fallen out of favor due to lack of outcome benefit in major trials and side effects. Why isn't D correct? May have an adjunct role, example high triglycerides, but doesn't replace statins for LDL-driven atherosclerotic cardiovascular disease risk. Let's move on to the final question. Question number 20. A patient started on a statin reports new onset muscle pain and weakness. Which laboratory test should be checked to evaluate for statin-induced myopathy? Option A, creatine kinase. Option B, troponin. Option C, D-dimer. Option D, erythrocyte sedimentation rate? The correct answer is option A, creatine kinase. CK evaluates for statin-induced myopathy or rhabdomyolysis, significant elevation with symptoms wherein statin discontinuation. Now, why isn't B correct? Cardiac specific used to evaluate myocardial injury, not skeletal muscle symptoms from statins. Now, why isn't C correct? Used to evaluate thromboembolic diseases such as DVT or PE unrelated to statin-induced myopathy. Why isn't D correct? A non-specific inflammatory marker doesn't specifically evaluate muscle breakdown the way CK does. Now, that wraps up this set of 20 questions. If you found this helpful, subscribe for the rest of the cardiology series. We have got 80 more questions covering valvular disease, vascular conditions, arrhythmias in depth, and integrative cases. See you in the next one.